Hello, I'm Claire Rusbridge. I'm a veterinary neurologist based at the University of Surrey and Weir Referrals in County Durham. I split my time between research, teaching and also seeing clinical cases. My particular specialty is neuropathic pain, and that's the subject of this discussion with Sarah Heath this morning. We are looking at the impact of pain on emotional health and how that will affect the behaviour of your pet.
So what are our learning outcomes then for this presentation? Firstly, we're going to think about understanding the concepts of nociplastic or maladaptive pain and neuropathic pain. We're going to think about that link between emotional and physical health components in these types of pain and consider the range of behavioural responses that can occur as a result. And then we're going to think about the process of identifying an animal with neuropathic pain, as well as considering some of the approaches to the treatment of them. So we've got a lot to get through in this next hour. So I'm going to hand over now with a little question to Claire. So Claire, what exactly is neuropathic pain and maladaptive pain? How do these terms link together, and can different forms of maladaptive pain occur at the same time?
Thanks, Sarah. So we really have to consider pain in three ways. First is nociceptive pain, and this is pain that is perceived in a normal functioning nervous system. So if I stand on a tack, then that hurts my foot, and two things happen. First of all, there's a reflex called the withdrawal reflex, which takes my foot away from the site of pain, but then that information goes up to the brain and is perceived as pain, and then that stimulates some sort of behavioural response from me. So I look down at my foot, take the tack out the foot, perhaps put the tack away and make it safer. The next type of pain is nociplastic. And nociplastic is fairly new term. Some people won't have heard about it. And actually, sometimes people call this maladaptive pain. Nociplastic pain is an abnormal pain state caused by ongoing inflammation and damage of tissues rather than nerve damage. And it's to try and encapsulate those pain states that result in an abnormal functioning nervous system, a central pain sensitization, but actually aren't as a result of a damage to the nervous system. So that will be very important to people attending this Congress, because osteoarthritis is part of that group. And so pain resulting from visceral damage, for example, a pain that you get with bowel pain, idiopathic bowel disorders and idiopathic cystitis, that's that sort of thing. So it's a huge group. In humans, it includes fibromyalgia. And then after that, we have neuropathic pain. And this is an abnormal state because of damage to the nervous system. And that damage could either be the central nervous system, so the brain or the spinal cord, or it could be damage to the peripheral nerve.
So when we think about these types of pain, Claire, what about whether they occur together? So you can explain a little bit more about these pain syndromes for us.
Well, I've listed them here, Sarah. These are all the sort of chronic maladaptive pain syndromes. Chronic pain in animals is not as well defined as in humans, and even in humans they argue about it. It's normally regarded in humans as pain that has a longer duration than 2 months, and in animals they sometimes question it should be a shorter period than that because they have shorter lives. But we'll say pain that has been long-standing, and they can be divided into chronic musculoskeletal pains, so things like osteoarthritis, chronic visceral pains, so things like inflammatory bowel disease and cystitis, chronic peripheral neuropathic pain and chronic central neuropathic pain, cancer-related pain, which is super underdiagnosed and recognized in animals and in humans. But when we actually consider that, there can be quite a bit of crossover between other pain groups. For example, if you have a tumor that is compressing the spinal cord, one could argue that that is also potentially going to cause chronic neuropathic pain. But because it compresses the meninges in its own right, the meninges have nociceptors, then it has its own classification in itself. And then the other thing that is often not looked at enough is pain as a consequence of treatment or surgery or radiotherapy, because that definitely happens in humans and it definitely happens in animals as well. And then a big group that I may see in my pain clinic is pain after surgery or after trauma. So, for example, oral pain after tooth root damage. Those trigeminal nerve endings are incredibly sensitive. Pain after orthopedic surgery and prolonged retraction of sciatic nerves, for example, thoracotomy pain, amputation pain, and where there's been surgery, where there was inadequate intra and post-operative pain control, because if you don't adequately pain relieve animals, then you can leave much more likely to leave them in a post-operative pain state.
Oh, that's really helpful. So what about the way in which this is generated, the neurology of it, if you like? You're the specialist in this area. What about what's happening in terms of the neurology?
Well, I'm going to talk through the kind of neurotransmitter level when I'm going through in pain treatment, because I thought, well, we'll only have to deal with the neurotransmitters once then. But once you get the signal coming from the nociceptor, it goes into the spinal cord at an area called the dorsal horn, and then it's transmitted up the spinal cord by various different routes, and then eventually hits the cortex. And we often refer to that cortex as the pain matrix. And that's not because there is an area in the brain called the pain matrix. That's really to describe a number of different areas which are not very anatomically close to it. The first bit that happens is that it goes to the amygdala. And the amygdala are very small areas in your brain that encode and consolidate the emotional memory of the event. Because it's very important, if you have pain, you actually remember you were hurt, because then you can avoid it, because the whole process of pain is that you learn from that experience. So if I learn that there was a tack on the floor, then I might avoid that, walking on that area of the floor in the future. If we can apply that to animals, then if they learn that going into a vet surgery is likely to result in pain, then they'll be unwilling to go into that vet surgery again. Then it goes to the hippocampus. The hippocampus relies quite close to it, and it's labelled in purple there, and that converts that short term to that long term memory. And they both together regulate your fear response by activating the hypothalamic pituitary adrenal axis. So, the hypothalamic pituitary adrenal axis will also influence that area. So, for example, if you are being chased by a lion, then you're obviously quite fearful of that lion, and when they catch, if they were to catch you, if you're an antelope, for example, and you had a broken leg, you may still run on that broken leg, because the hypothalamic pituitary axis kicks in with your fight or flight response to make you flee from that. But these areas will also activate your fight or flight response and make you want to avoid that area. And then our next bit of this corticolimbic circuitry is the cortical areas, so things like the prefrontal cortex and the cingulate gyrus, and they receive an awful lot of inputs, the somatosensory, visual, auditory, and emotive inputs, and they plan your complex cognitive behavioral response. So this is where you kind of may rationalize it. Okay, maybe I was hurt by a tack when I walked across the room last time. What are the chances of being hurt by a tack next time I walk across the room? As a human, I'm able to put in a bigger interpretation into that, because I have a bigger forebrain. Animals, of course, may not be able to make that cognitive jump. And that's, I think, something you're going to be talking about, Sarah. And then when we look at the pain matrix, we can really divide it into three sort of areas. And so it's connected to this hypothalamic pituitary axis, and that will input your decision making, your emotional regulation, and your memory. And they will also modulate your acute pain, but it's very important. This is critical for the chronification of pain. So all these areas are really critical for making pain go from that acute to chronic. And the thing is, these areas overlap. And so this corticolimbic circuitry that's involved with emotion, it's obviously overlapping with pain. And that means that chronic stress can actually open the gates and make you more susceptible to being painful, and vice versa, that when you are painful, you're more susceptible to having mental health problems and even very complex neurobehavioral syndromes.
So let's look a little bit more then about the function of the pain matrix.
So the function of the pain matrix, we often divide it into three hypothetical areas. So the first area is your sensory discriminative dimension. So this tells you where the pain is and how severe it is. So I stand on the tack, I think, ouch, where is that? It's my foot. And therefore that will direct me to deal with that. The next area is your effective motivational width, which is your emotional response to that pain. And so being hurt obviously stimulates an emotion. It might make me angry at the tack on the floor. Why is that there? All the health and safety of it all. And then the next stage is our cognitive dimension. And this is where pain demands a behavioural response. I need to do something about the fact that I have been injured by attack. Right, I'm going off to the people in charge of health and safety and ask why it is that they've allowed a tack on the floor which has damaged my foot. I might also self-reflect and think, why am I walking across this floor in bare feet, and put something more protective in. And this cognitive defect will affect all other cortical processes as well. So it has to be integrated with your other decision making. So you may decide to ignore that pain if there is something else that is more important to you. So if I have incredibly severe dental disease, like many cats, I may decide to ignore that pain because I want to eat and I don't want to starve to death. And I think there's an important lesson there. Just because an animal is eating doesn't mean that they're not painful. Most animals don't choose to starve themselves to death. And it's very important to remember with this cognitive dimension that pain predisposes, as I've said before, these stress-related behavioural disorders and vice versa. And that's what really my question for you, Sarah, is what sort of behavioural presentations do we see with neuropathic pain?
Yeah, this is where it gets really interesting from a multidisciplinary point of view, and why we work together on these cases. Because when we're dealing with the behavioural side of things, there are quite a range of different ways in which behaviour can be influenced by the emotion of pain and the physical sensation of pain. So let's think of it in terms of the altered sensations to start with. So neuropathic pain, as you've just described, when it's associated with those peripheral nerves, can lead to quite altered sensations in the skin, for example. And we sometimes see behaviours which are reported by caregivers as a behavioural concern because they're a behavioural response, but they're coming from that abnormal sensation. So some examples of that might be changes in their facial expression. So some grimacing, which you look here, these examples from these Cavalier's photos, thankfully coming from Claire here, looking at the change in facial expression, sometimes referred to as a pain face. But they're not more obvious behavioural responses like rubbing of the head or shaking of the head. Obviously, when we get these sorts of responses, we might have other things on our mind, like maybe dental pain with the mouth rubbing, or ears hurting with the head shaking. But we need to remember that it can be more complex than that. Of course, we want to do a clinical examination and make sure we've ruled out those other options first, but neuropathic pain could be responsible. And then because of those peculiar sensations, we may also get things like nibbling at the skin, or maybe abnormal movement of the skin, so rippling responses. Now, one thing I haven't included here in this particular slide is scratching, Claire. And I did that because I know you always have something to say about making sure we don't confuse scratching with neuropathic pain, so particularly in the realms of phantom scratching. So I'm going to let you just come in here, because this is very much your baby.
Well, we have a neuropathic pain complex called canine Chiari and syringomyelia. And dogs with canine Chiari have behaviours that suggest head pain. So they will rub the head, a bit like your French bulldog there, and maybe scratch at the back of their head. And if we speak to humans with Chiari malformation, we know that they get head pain, especially at the back of the head. However, in syringomyelia, you can have damage to the scratch area of the spinal cord, which is the mid-cervical spinal cord. And this can give a phenomenon called phantom scratching. And I just wanted to make the point that this is not neuropathic pain, but it does share some features. It's a maladaptive scratch reflex due to that damage. And so you can tell when they have phantom scratching because you can rub the dermatome, the area of skin that's associated with the spinal cord that's damaged. And that will elicit this sort of scratching action, which is very reflexic. So they kind of make this breeders will often refer to it as playing the air guitar, and they don't tend to make skin contact, and they also twist their head towards the scratching side, as you can see in this dog. You will also see that with emotional arousal, and this dog's been taken for a walk, their neck collar that's stimulating it. One of the important things to remember, though, is that because they have this damage to the spinal cord, they can have phantom scratching and neuropathic pain. In fact, that's much more common. So they will often have vocalizations, behaviors suggesting head pain. They might have hyperesthesia, which is increased sensitivity to a normal level of stimulation. So, for example, you put your hands on this dog's necks and they jump more than you would think they would. And they may have allodynia, and that's pain from a stimulus that's not normally painful. So often when you touch these dogs on their paw, they will react to that more than you would actually expect. So this is an example where you can have two sort of different phenomenons that are similar but not quite the same. And so I was going to ask you further, Sarah, about what sort of behavioural presentations that you see with neuropathic pain.
So when we think about changes in behaviour, we can think about the fact that neuropathic pain can lead to some resistance to movement. So where there's more of a physical impact of this neuropathic pain, and that can lead to posture changes. You can see here in this photograph, this kyphotic posture related to being in discomfort may cause gait changes. You may see abnormal placement of limbs. And sometimes we get other changes as well that are more this physical association with neuropathic pain, maybe things like panting. And then in this video, we can see that we can get quite a range of responses that are actually suggesting that this dog is quite distressed. So a little bit of panting, some gulping, some just general agitation, animal unable to settle. So we can see these behaviours which are very much related to the physical impact of the discomfort or the pain that's coming in this neuropathic case. But we also have a situation where it can be slightly less obvious than that. So some of these alterations that we get in sensation, and then they change their posture or their gait because of the impact of that sensation, that can actually exacerbate other emotions, such as fear, anxiety. Now, we'll talk about this a little bit more later, but fear, anxiety, and pain are actually related to each other in an emotional sense. They're part of the same emotional system, if you like. But when you're in that state of pain, you've got that slightly abnormal sensation, it can make you more worried, particularly if there's a perception that you're unstable. So if you don't trust your body to carry you, then that can make you very anxious. And that can be exacerbated in many of our patients by the sorts of floors or surfaces that they are being expected to move on. So if they already have a situation where they are not really trusting their body because it feels odd, and then they're trying to move on a surface that's slippery and doesn't give them stability, then those things can compound their protective emotional state of being fearful and anxious. And we may get reluctance to walk on those surfaces. Maybe they don't want to go across the conservatory, which has got a really slippery floor, and that's the only way they can get out to the garden in order to relieve themselves and go to the toilet. And so we may actually get a presentation that this dog is house toiling. The reason is that it can't actually get across that piece of floor to access the garden because of the pain and feeling unstable. So we can certainly get these slightly more complex relationships between the pain and the behavioural presentation. The other thing that can happen, because again of this abnormal sensation, is that these dogs can be quite reluctant to be handled, and they can be quite reactive when people even disturb them where there's a potential that they're going to be handled. So if they anticipate being moved, or if they need to move in order to gain access to something else, so maybe it's tea time and they want to be fed, but actually to be fed, they're going to have to move themselves to get to where they need to be. That could trigger a behavioural response through the emotion of being fearful and anxious about that process of being moved, moving, or being handled. And when these sorts of interactions happen, a repulsion response is probably the one that's the most problematic from the caregiver's perspective. So repelling behaviours are, in the Heath model, which we'll talk about later, we describe behaviours that are designed to push something away, to increase distance from it. We call them repulsion behaviours. So it might be a growl or a grumble, or it may be a snap. But we need to remember that that's not the only way in which an individual can protect themselves. So sometimes protection comes through avoidance. So it's moving away from the potential of being handled or disturbed. But also, dogs particularly, dogs are socially obligate creatures. They like to retain social contact. So growling at someone is likely to make them go away, and me cowering and moving away from them means I can't get the benefit of interacting with that person either. So sometimes we go into these different behavioural responses of inhibition which is a sort of shut down physical response, but the sensory system is really busy. You can see the dog here, you can see it staring, you could see it as this is a video rather than a still. You'd be able to see that nose moving, gathering olfactory information, the ears are moving to get auditory information. They're finding out as much as possible about this environment that they're in to try to mitigate the potential for there to be pain if they are handled or disturbed. And because they're sociable creatures, dogs may sometimes, instead of using this passive way of gathering information, they may actually want to gather that information more actively by interacting with the person, but they interact in ways that help them to get information from the person. Now, these sometimes can get a bit misinterpreted. We can understand this licking as being like kissing someone. So we can look at it and see it and think, oh, they're really happy and they're engaging and they're showing affection, when actually the individual is just trying to gather information, trying to find out whether or not this is going to be a difficult situation. So it's a protective mechanism that they're using. So we can see that it might be direct because of the physical discomfort. It might be because of an anticipation that being handled or disturbed is going to cause that discomfort. And then we have another way in which these emotions can lead to behavioural responses that are designed to resolve the situation. So they try grumbling or moving away or inhibiting or appeasing, but often those behaviours can't resolve that neuropathic pain. We need to resolve it in other ways, which we'll talk about, and Claire, you'll talk about that in more detail later. But if this animal perceives that they can't resolve this discomfort, that can lead to another emotion, an emotion called frustration. Now, frustration is triggered through failure. It's triggered whenever we're unable to do something that we want to do, when we're unable to achieve our aim. And the thing that happens with frustration is that it has a really important impact on the behaviour of the individual in three main ways. So it increases the speed, it increases the intensity, and it makes that behavioural response more likely to be confrontational in nature. And the impact of that, of course, can be that because they are more confrontational and they do it faster and with more intensity, we may actually find that in this situation, we end up with more risk to the caregiver. They're trying to handle or move the animal, or the vet when we're trying to interact with them, but maybe also more risk to other animals in the household who are approaching the individual, maybe with pleasant intentions of wanting to play with them or rest with them, but that can trigger a perception in the part of the patient where they feel they can't resolve this situation. They've tried using communication and body language to say, I'm uncomfortable, and then they get frustrated. So frustration can be a really important part of this issue.
So, Sarah, are there other ways that pain can affect behaviour other than a direct relationship between the pain and the animal trying to protect themselves, for example, by not moving?
Yeah, absolutely. So if we think about pain, emotion of pain, there are two aspects to this which can influence the behavioural output. So first of all, the valance of the pain. So pain is part of the fear-anxiety system. And I said that earlier. And in Panksepp's model, so Jack Panksepp was an Estonian biologist who did a lot of work looking at the emotions that drive behavioural responses in both human animals and non-human animals. And he talks about pain as being part of the fear-anxiety system. And that can be a real problem when we're trying to diagnose, something we're going to talk about later. But often these animals can show behaviours that are very difficult to distinguish whether it's coming from fear-anxiety or whether it's coming from pain, because they're related to each other. They're both protective. The Heath model of emotional health, we talk about protective rather than negative emotions. So Panksepp uses the words positive and negative. He's absolutely right, because he's using them in relation to positive, meaning you add something, the negative meaning you take something away. But actually, the negative word in the English language is actually quite loaded. We say the word negative and people tend to think bad. It's really important to remember, as Claire, you've just pointed out, that you needed to get your foot off that tack, otherwise you would have been in more damage. So it wasn't a bad thing that you felt that pain. It's not an unwanted emotion. It's actually a protective emotion. And so that's why we use that word in the Heath model to tell us more about the way in which the emotion is aiming to alter that individual's survival. course, there are engaging emotions as well, which increase your survival by gaining access with something like food or shelter. And you gave that lovely example of dental pain, where these two types of emotion might be in some conflict. And then it's the one that's the predominant one, that's the one that's going to lead to the behavioural output. So we talked before about behavioural responses, either increasing distance from and decreasing interaction with a trigger, or increasing availability of information about the trigger. And so these behaviours I just talked about in relation to the physical perception of pain will also be seen in relation to fear anxiety, that other protective emotional state. And so that can make the diagnostic process quite difficult. So how does pain actually impact on emotional health and thereby influence behaviour other than this direct level? Well, one of them is the fact that pain can impact emotional stability. So I'm going to talk a little bit about the Heath model in terms of three components of emotional health, because the aim is to maintain emotional stability, to have emotion that can be coped with, if you like. So we have the capacity for emotion, and in this model, we liken that to a sink. And then we have the input of emotion. I just talked about this difference in valance. So when we're talking about pain, we're talking about this red tap, the hot tap, the protective emotion. But remember, we've got these other emotions that are happening as well, because emotional health is very dynamic. So we're going to have engaging emotions like desire seeking to have food, social play, to play with your fellow members of your species. And then this emotional conflict potential of more than one emotion at the same time, with that poor animal that has dental pain, where the blue tap, the cold tap, is saying eat the food, and the red tap, the pain tap, is going protect yourself. And then we need to have that conflict between those types of emotion. And then we have drainage. How do we get rid of emotion once it's served its purpose? So emotional arousal is the result of the balance between those three. If you've got a good balance, then you can maintain a low level of arousal. We represent that by the level of emotion in the sink, and the aim is for that to always be at its minimum. So when we think about an individual who's in pain, we know that pain is the red tap, it's a protective emotion. I've just also said that it's accompanied often by other emotions that are protective. So fear, anxiety, frustration, they are likely to be seen, particularly when we're in a situation of chronic or maladaptive pain, when it's not resolving. Then that increases that protective input. It increases the amount of water coming in from that tap. And that impact of that increased protective emotion is going to be very variable between individuals, because it's going to depend on other things. You've turned the tap up, that's important, but is there any other factor of this individual that could mean that that dog is more likely to go on to have problems? So maybe it's got a small sink. Maybe its emotional capacity is not actually very high, and therefore if we turn that tap up, we're more likely to cause a flood. It may be that there's other emotional input. It could be coming from the hot tap through fear, anxiety unrelated to the pain. It might be frightened of traffic, frightened of people, or it may be coming from the engaging tap, the blue tap. So it may actually be that this dog's having a lot of emotional input, but it's fun. I'm playing with a ball, or I'm playing with my mate. But that's going to increase input and put more strain on the capacity of this individual. And then if the emotional drainage is not up to speed, then that could also mean that we're at more risk of flooding. So high emotional input will increase the potential for that protective element of your pain to have more noticeable effects. So if they've got an emotional disorder already, they've got an anxiety disorder, and then they develop neuropathic pain, or they've got some other physical illness present that's creating discomfort, or maybe changing their ability to cope with their emotion, or maybe they're just having a lot of fun, so someone's playing with them, or maybe they're in a situation where there are fireworks going off and they're frightened of noises. If all of these things are happening, then there's a potential that there'll be a variation in the reported impact of the pain at those times. This is actually one of your cases, isn't it, Claire? This is Charlie, who you saw, who had a problem with thunderstorms, but his situation of his pain from his Chiari malformation and syngomyelia, so he had that pain, but when there were thunderstorms and his emotional input was increased because he was frightened of the thunder, then it exacerbated how much he expressed that pain and how he coped with his pain medications. So we can have this input, this variation on the reported impact of pain. And then the other way around. So if we've got high emotional residue already, that can increase the potential for other emotional inputs to create greater behavioural change. So if that sink is already full of pain, so pain is the main emotion that's filling up the sink, and then we start another input, for example, we increase noise-related fear, or we have social anxiety, or maybe we're a little bit worried about a resource, then we're going to increase that level even further and potentially cause a flood. So this little video here.
You resource guarding.
You can hear the caregiver there say, are you resource guarding? You can see the bed here. He's worried about this bed. It may well be that his behaviour over enjoying his bed and feeling that his bed is potentially under danger is exacerbated by the fact that he's in pain. Engaging inputs can also, though, increase that flooding. So we can get variation in the reported impact of the emotional challenge from other sources because they're in pain. So it works in both directions. So how emotion can impact on these responses, how behavioural responses can be changed by emotion.
I was wondering whether you'd be able to help me with one of my cases, explain some of these things in a little bit more detail. Also, I wonder if you can explain more about the cognitive health aspects of pain.
Okay, so let's actually have the discussion. I'm sorry, that's my mistake there, not advancing quickly enough. There you go. You can tell that this is genuine, this presentation. We haven't fudged it. So here, sorry, Claire, you wanted me to give advice about this case and I forgot to advance the slide. So over to you again to talk about the case.
Yes, sorry. This is one of my cases that I've recently been asked about, and it's a little Cavalier King Charles spaniel, and it was obtained from what was thought to be a reputable breeder. The owner did her homework, she thought, and it came from a litter of 9 puppies. And she saw mum, and everything seemed to be okay. The notes from the vet suggested a pretty normal puppy, and they vaccinated it and did all the usual puppy things. And when they saw the dog in November, a couple of months later, then the caregiver reported that basic training was going really well. The local vet then saw it again in January, and this is when it started showing signs that in hindsight are pretty typical for Chiari pain. So vocalization when jumping, so a sort of valsalva mimic, which means a sudden change in thoracic pressure that you get when you jump, results in pain in these dogs. Occasionally when being touched, so increased sensitivity, hyperesthesia, certainly, possibly even allodynia, and also a vocalization when he was on walks. It obviously went to the vet, and the vet found that the dog was hyperesthetic in the neck region. Because of the breed, they referred to a neurologist, and in between that time, the dog developed a real problem with resource guarding. The dog then had an MRI scan investigation in February this year, and it identified this canine Chiari and syringomyelia. And I don't have the pointer on my side, but perhaps Sarah is able to point to the spinal cord area. Yep, there we go. And then right in the middle there, we have a area of fluid-filled space, which is syringomyelia. We've got a line going through there. It's quite a small syrinx in this dog. It's fairly symmetrical. It's probably not the syrinx that's causing the signs. We haven't got the images of the brain there, but there's certainly an indentation of the cerebellum with the ligament that goes between the back of the skull and the atlas. It should be horizontal. It's not in that dog, it's vertical. So we know there's a very short back to the skull, and I'm sure we would see other changes if we had the whole MRI scan to be able to diagnose canine Chiari. So this was what was diagnosed, and the dog was started on, again, what in hindsight seems to be quite a low dose of gabapentin. Normally we start at 10 milligrams per kilogram. The vet also gave some metacam, and there was some improvement, but then the behavioural problems escalated.
How do you know?
There's a couple of interesting things here. I hope you're all noting the slippy slidey floor that we've just talked about earlier, that sort of surface can really exacerbate the fear anxiety component of this issue.
From what I know about this case, I think they're trying to move the dog away. I think they're having trouble actually walking across their kitchen because he is guarding the area.
Yes, you can see that that resource of space being worried. So again, if we think about the link between the emotion and the responses, maybe that there is some direct response here because he's uncomfortable and people coming towards him might mean he's going to be handled, as we talked about. We've then got the slippy slidey floor and the feeling of being unsafe and unsure about his footing. So that's going to make him more fearful and anxious. Then they bring some food in, which is quite a good way of doing this. So they're going to use food to turn on the cold tap and get more of that engaging emotion and therefore move him without touching him. Very wise. So that's what we do want to do. We don't want to be moving him by directly handling him. So we're going to use it passively. But we're going to be a little bit careful of when we're using that food is that we don't turn that cold tap on too high, because this dog's not got much space left in his emotional sink. And if we do too much in the engaging department, then we actually may push him even closer to his threshold. So I would be using that food as they are doing, maybe putting it more passively, maybe also because it's a slippy slidey floor, maybe just placing it rather than dropping it because it's bouncing. And as it's bouncing, it increases that excitement, if you like, the more, oh, where's the piece of food? And then it's going to encourage more movement. That could trigger more pain. So we could use just a very quiet food trail, maybe a scatter of food so that it's not so reliant on the caregiver as well. So just a spreading out a bigger scatter of food rather than dropping individual pieces.
No. In your crate. In your crate. Coachy, back off. Look, in you go.
I'd love for you to interpret this one for me, Sarah, because I noticed that the caregiver has a pillow when they're approaching the dog. They're obviously worried that something's going to happen, and but they do successfully move the dog into the crate, which I presume they were. And again, I think that the dog is blocking the exit there.
Yeah, absolutely. This is fascinating behavior, isn't it? And this little dog. And you can see, again, it highlights really nicely what we've just talked about this emotional connection, because there's an anticipation here. The caregiver's not doing anything. The caregiver's not actually caused any sort of threat. But you talked earlier about the memory of discomfort and pain. And so this poor little chap, if he's got an association with that memory of that pain, then he's going to be anticipating that you trying to move me is going to be painful, could make it difficult for me. Therefore, he's becoming protective in advance. And as you say, there's the caregiver also showing protective behaviour because they've obviously had a bad situation before where maybe they've been bitten or challenged by their dog, and therefore they are reacting with fear and anxiety. They're bringing in their pillow. I think the pillow there is being used mainly protectively for the human. They're not, I don't think they're trying to use it to move the dog. I think they're trying to use it to protect themselves. But we've got to remember that the poor little dog is going to see this large item looming over it and coming towards it and have a perception that it may actually be something threatening to them. So yeah, having the enormity of the pillow, if you like, and probably the fact that the way it moves may exacerbate that fear and anxiety. And again, then trying to get him into the cage. And he's going into the cage more because he's trying to avoid something he doesn't want rather than going into the cage to get something he does want. And we can think about that when we're trying to change these behavioural responses, to think about trying to get them to move in a different direction because that's what they want, because that's the more pleasurable outcome rather than they're trying to get away from the thing they don't want. So yeah, really lovely case of very obviously a physical health condition, but also with an emotional component to it. And then there's the cognition, the memory, the learning as well. So beautiful example of the triad of health that needs to be considered in these cases.
Thank you very much. We're going to talk more about managing those cases, but before that, could you tell me more about the cognitive aspects of the pain?
Yeah, so cognition is the third part of the health triad. And we know that there's different ways in which associations between pain and behaviour can develop through learning. So pain can have a cognitive impact. And because it's an emotion, it can be associated with other stimuli through a process that we call classical conditioning. So in classical conditioning, you've got a stimulus that's leading to an emotional response. In this case, a pain-inducing stimulus that's leading to the pain response. And then it's occurring in a certain context. So maybe it's happening when the individual's at the vet's, or maybe it happens when the individual's on a walk. And that ties nicely into the case we just talked about, where you said that those vocalizations occurred when he was handled, but also when this little chap went for a walk. So the potential for that pain to be associated with a particular context. And if that happens again and again, then we get what's called classical, or sometimes referred to as Pavlovian conditioning. And you may be remembering from school days Pavlov's dogs, when they were in the laboratory and food made them salivate, but then the metronome tone was sounding in the laboratory. And because that happened, that sound of the metronome happened at the same time as the delivery of the food, that eventually the metronome could make those individuals start to salivate even when there was no food. And the same way, that context of a veterinary practice or going for a walk through classical or Pavlovian conditioning can be associated with the pain, such that just going for a walk can create a pain emotional response, even though there is no physical sensation, maybe because we've got our analgesic pain relief really right and we've got that pain really well under control. But if this classical conditioning has already occurred, then we may still get those contextual associations. And then there's another form of learning. So this form of learning is called operant or instrumental conditioning. Now, this type of learning increases or decreases the probability that a behavior will happen again in the future. And the way it does it is that the cue leads to an action, the animal responds, does something, and then there's what we call a consequence from that action. So the behavior has a consequence for the individual, which then alters the probability of that action happening again. So if we give this individual who has discomfort and pain a verbal cue to sit, and this dog has learnt that through previous associative learning, that means I should lower my back end to the floor and adopt a sit posture. So because the dog has learnt that, he complies with that, he responds to that cue and goes into a sit posture. But if that leads to maybe pain, maybe neuropathic pain because there's some intervertebral disc disease, for example, then that pain is a consequence of that action and will decrease the probability that that animal will adopt a sit posture again when it hears that verbal cue sit. And that can lead to some confusion because we can think this animal's now becoming stubborn or disobedient or difficult, because I'm sure he knows the word sit. I can't understand why he's not going into that posture because he knows what that means. But if there's some discomfort, then that could be affecting that behavior by operant conditioning. So those are two learning aspects. But I want to go back to something you said earlier, Claire. You talked about memory. You were talking about the amygdala and the hippocampus and how they're involved in memory formation associated with pain. So we can have a direct impact through the memory of the pain leading to this anticipatory behavioural response in the future. And examples of that might be a dog that avoids the context you mentioned earlier. Maybe they're not going to want to go to the vets anymore. She's like, you're not going to want to walk barefoot across that stage anymore. So we're going to avoid that context in the future. But also, we can have an indirect impact of that protective emotional state on memory. Because we know that when you're in a protective emotional bias, what that basically means is that you've got more red tap than blue tap coming into your emotional sink. That favours the formation of pessimistic memory. You're more likely to remember those things that could potentially cause you harm. That's very biologically adaptive. If you have had a protective emotional response, therefore you're going to think about and remember the things that could potentially harm you. And that can increase the level of fear, anxiety in relation to other triggers. So Charlie, who we mentioned earlier, your case with the thunderstorms, that memory of the thunderstorm is going to be a more pessimistic memory, an enhanced memory of that, which means his next response to thunderstorms may actually be worse. And then finally, in cognition, pain also can influence memory through its impact on sleep quality. So sleep is incredibly important in emotional regulation, but also it's important in adapting your brain and the way that you deal with these protective experiences through something called amygdala adaptation. I'm going to mention that later, but also through what we call memory stripping. So emotions, you talked earlier, Claire, about this when you were talking about the amygdala. You said how important it is that we form a memory of that emotion. We need to know that that was an unpleasant sensation, but actually you don't want to hold on to the intensity of that memory of the emotion. You want to slightly lessen the emotional intensity, but keep the memory of the event. So not necessarily a pain example, but I think this is quite a nice example for us humans to relate to. If I'm walking along a road and I absent-mindedly step out into the road and nearly get hit by a car, then I'm going to have an emotional memory of stepping into the road absent-mindedly, because it created, hopefully not real pain, because I hope you don't get hit by the car, but certainly an anticipation of being threatened by the car that was coming towards me. So I'm going to have this really emotional memory of being terrified when I stepped absent-mindedly into the pavement, off the pavement and into the road. But if I want to be able to survive, I don't want to have that intensity now every time I walk down a pavement. I still want to remember that absent-mindedly stepping into a road is a bad idea. So I want to have the memory, but I don't want to have that terror of being so frightened, but eventually I can't walk down the pavement at all. So this emotional memory stripping happens during REM sleep. And so therefore, if pain is affecting the quality of sleep, then that can also influence the emotion or the memory as well. So again, another way in which there is a cognitive impact. We've looked at emotion, we've looked at cognition. Now I want to move on with your beautiful diagram here, Claire, to the idea of how we actually diagnose neuropathic pain. So can you talk us through this process as to how we get to the point of actually knowing that we have a situation of neuropathic pain?
We should clarify that a little bit, because actually neuropathic pain isn't a diagnosis in itself. It's a bit like anemia in that sense. It's a clinical observation. And the question is why? Why is there neuropathic pain, not just that there is neuropathic pain? And I put these sort of 4 prongs here really because some of these things can be easily ticked and you get the diagnosis, but sometimes it can be a little bit more challenging, especially if you don't have access to the diagnostic tests. So I'd say the most important thing actually is having a history of having that damage. So we have, should we say, for example, history of an orthopedic surgery where the sciatic nerve was retracted during the surgery and not dynamically retracted, which means you take the pressure on and off, but retracted during the whole procedure, which is much more likely to give damage. If we have that kind of history, then that is one important key point. If you don't have that kind of history, then you may be able to have diagnostic tests which show the lesion, for example, an MRI scan or neuroelectrophysiology, which is a way of testing nerve function and muscles to show that there is a damage to the nerve. But another important aspect of neuropathic pain diagnosis is evidence of abnormal sensation, either decreased or increased sensitivity to touch. And you may be saying, Sarah, what do you mean decreased sensitivity to touch? Surely that would suggest they don't have neuropathic pain. Well, that's because in many animals that have neuropathic pain due to a peripheral nerve injury, they may actually also have a degree of numbness or hyperalgesia or even analgesia in some areas. So, for example, a cat with that or dog with a sciatic nerve lesion may actually have reduced sensation when you to touch. They may have reduced reaction, but they have evidence of experiencing abnormal sensations, which we call paresthesia or dysesthesia. And you may say, well, how do we know they are doing that? Well, they may be mutilating that area or have other ways in which they're protective of that area. But in some instances, it can be quite challenging to make that diagnosis. And I do think that there is an argument, especially in general practice, to say maybe there is an option for a treatment trial. So if you have a suspicion, maybe there is some suspicious history, if you give a trial of drugs that affect neuropathic pain, nociplastic pain, and they have a strong response to that, then it's an argument that that's a problem. You may be arguing, actually, Sarah, with me. You may say, well, some of the drugs that you use, Claire, actually affect cognition as well, actually might affect fear and anxiety. You may give me an example of pregabalin. And I would say, yeah, that's true, Sarah, but in a real world, don't we want to find a treatment that just makes the animal happier? So yes, maybe if I am treating its fear and anxiety, then and not its neuropathic pain, then I don't have an accurate diagnosis, but I do have some sort of treatment.
I think you wanted to just mention the Chiari check, which we can do quickly, and then I'll just look at some of the ways in which we can approach those emotional sides before we finish with how we manage these problems.
Yeah, I just wanted to highlight this. Chiari pain is quite difficult to diagnose, and we do have a questionnaire checklist that can help you in that respect.
Okay, so in terms of the emotional and cognitive aspects, we can just summarize the fact that we need to always think about the fact that physical, emotional, and cognitive health are factors that coexist. It's not one or the other. So to determine the relative contribution from emotion, we're going to think about whether we've got those behavioural responses we talked about and that body language that suggests protective emotion. We're also going to think about whether there's any high level of emotional arousal. Is the sink already full? And there's a little overflow hole at the top of the sink where displacement of water happens to stop a flood. And we have the same with behavioural responses. So we can get responses like yawning or lip smacking or shaking, scratching and self-chewing can also happen here. That could be difficult with neuropathic pain cases because we just said that could be coming directly from the pain as well. But these are indications that the sink might be full. And then the other thing we think about is there any evidence that the drainage is compromised? In dogs, they drain out through their chewing and also through their sleeping. So if we've got any of those triggers, then that pushes us towards thinking there could be an emotional component. So we're going to wrap up on management then, Claire, management of neuropathic and nociplastic pain. And we'll just give a quick run through this because as I say, we're going to try and wrap.
I would say that this is quite a complicated subject, and I have quite a few supporting videos which you can access through that YouTube, both on canine Chiari and neuropathic pain. But I thought I'd just very briefly go through a couple of drugs which may be more applicable. Otherwise, the drugs can be accessed by dedicated videos. The first one I wanted to really sort of mention was the monoclonal antibodies that target NGF. Now, of course, these drugs license for treating, if we go back one, license for treating osteoarthritis, but what people may not realize is that actually their site of action is the dorsal nerve root ganglion, and they interfere with the nerve growth factor, which makes in a lot of changes in that dorsal nerve root ganglion, resulting in overexpression of many compounds. And so actually, though it's not licensed for that use, theoretically these drugs could be used for targeting peripheral, not central, because the dorsal nerve root ganglion is peripheral, but peripheral neuropathic pain. The next drug I wanted to mention is really affecting the spinal cord, and this little star here is meant to represent the superficial dorsal horn, which in the little bit of spinal cord that you've got there is a tiny bit of purple right on the over edge. And when the nerve signal comes in from either the C fibers or the alpha delta fibers, it releases a neurotransmitter called glutamate and also a substance called substance P. When that keeps on firing, which Sarah's going to do by advancing the slide again, so it's got firing, and then eventually when it fires, that magnesium block comes off, and then that allows opening of something called the NMDA receptor, and that NMDA receptor is important in something called wind up. And so what that does is it causes a lot of changes on the postsynaptic membrane. We get more receptors, we get release of nitric oxide, and we get release of more transmitter. And what that basically means is that that is in a wound up state. And this is one of the changes that result in something called wind up and then central hypersensitivity. So if we can stop that process, that would be great. And so one of the drugs that we can use is in the next slide. And so we have a release of that magnesium block and release of that glutamate that's going to bind to that receptor. Then if we give a drug which stops that glutamate, the gabapentinoids, things like gabapentin and pregabalin, we can prevent that glutamate release and slow down that wind up. Now we can combine that with a drug which actually can reduce that NMDA receptor. So sometimes we will use periodic or one-off ketamine. That's ketamine given by a single injection. And so in this, what ketamine does is if we see that the glutamate is being released again there from there, and we're getting action potentials coming on now. Yep, there's the action potential. And then after that's had enough, we get the magnesium block going away. And then we get glutamate binding to that NMDA receptor. However, if we give ketamine, there it will actually bind to that glutamate binding site and block the receptor. The other drug that we can use is something else that is blocking that NMDA receptor. Slightly different way. I think these molecules are really cool. As memantidine and amantadine. So when the magnesium block comes off, so we have the glutamate coming off, the magnesium block is going away like that. And what these little molecules do is they actually act as a bridge, just like the magnesium. So you can see they've got really 3D structures and they block that NMDA receptor. So in many instances, we can use these drugs in combination, a polypharmacy, to affect our wind-up, our central sensitization, and this nociplastic and neuropathic pain. In addition to your cognitive and behavioural approaches, Sarah, how do you address those?
Yeah, so finally, we're going to address the emotional and cognitive components. So when the behaviour is directly related to the physical component of pain, then of course we need to do exactly what you've just talked about, use appropriate medication, maybe surgery in some cases. But when the behaviour is related to emotional burden, we also need to think about altering that emotional bias. So that will modify how the individual perceives their pain, increasing their engaging bias, for example, through play, as we can see here, increasing triggers for that engaging emotion, as well as increasing the perception that they can cope. Remember, we talked about frustration. So this little Daxi here being allowed to dictate where he lies and the person being passive with him and not interfering and not trying to touch him all the time. Decreasing any other triggers as well for protective emotion are going to be important, as well as using cognitive approaches. So here we have the individual being taught to touch as a cue for being handled, so they have some control over that interaction. And then also think about improving emotional drainage through opportunities for chewing, opportunities for sleeping that we discussed earlier, those really important drainage behaviours. And if the behaviour is related to memory, then of course we're going to actually want to form some new behavioural associations in those contexts where there's been pain previously. So I'm going to hand over to you, Claire, to wrap up with our conclusions from our little chat this morning. Over to you.
So, in conclusion, well, pain is normal. We need it to survive. It demands a behavioural response to protect the animal, and the painful experience results in a memory so the animal can learn to avoid it. However, you can get these abnormal pain states, which we call nociplastic, when it's related to things like osteoarthritis, and neuropathic, where it's related to damage to the central or peripheral nervous system. And these do not benefit the animal and are a disease in themselves. And they impact and are impacted by cognition and emotion. So you need to consider management strategies that will reduce these central sensitization, like the drugs, and you need to consider management strategies to address the emotional and the cognitive components. Thank you very much. Thanks for listening to us.